Consultant ophthalmologist from Grantham Hospital, Hong Kong. Her area of special interest is ROP and related work, and she'll be sharing her latest work on the new way to look at ROP. So Dr. Connie, please.
Okay, thank you very much. I'll share my screen. Okay, good afternoon, evening, morning to everybody. Before I begin, I would like to thank the moderators of the APSPOS and also the AIOS Society for their kind invitation. And my topic will be on the future trend of ROP screening in Hong Kong. And I have no financial interests to declare. So before I begin, I would like to acknowledge the following doctors, also the pediatric service at Queen Mary Hospital and also Prince of Wales, and also the neonatologists, nurses, and clerical staff at both of these units. So why is ROP such a global issue? So if we look into a report that was published by the WHO in 2012 called Born Too Soon, they identified that the rates of premature births are on the rise. And the majority of these births are in sub-Saharan Africa and also in Southern Asia. Not only premature births are rising, also preterm births of less than 28 weeks, kids that are most at risk, are also rising as well. And also, we also need to remember that ROP is one of the top causes of childhood blindness. So for ophthalmologists like us, we have to make sure that we screen for ROP and disastrous consequences do not occur, because at a click of a button online, you will be able to find a lawyer that is very willing to sue you. So what is retinopathy of prematurity? So it is a disorder of premature low birth weight infants featuring abnormal proliferation of developing retinal blood vessels at the junction of the vascularized avascular retina. So this is a short diagram that summarizes the two phases of ROP. So when a premature infant is born, it is subjected to a hyperoxic environment in which we have one phase of ROP, which is the vaso-obliterative phase, the decrease of VEGF. And because of this ischemia that occurs, then we go to phase 2 of ROP, in which we have a proliferative phase, in which there's neovascularization and also consequent increase of VEGF. So what are the risk factors of ROP? We know for a fact that gestational age, birth weight, multiple births, and oxygen saturation play a role, and there are also other factors that have been identified. The International Classification of ROP2 has identified ROP into 5 stages. We actually want to prevent severe stage 3 progressing to stage 4 disease, in which we encounter retinal detachments, and then that will need surgical intervention, and visual prognosis of this condition is not very good. So therefore, screening is very important, but we are victims of our own success. There are cases in developing nations on the rise. We have more extreme low birth weight babies and premature infants that are surviving. Therefore, we have more NICUs. Then we need more people, more resources, more nursing staff, and then more training. Easier said than done, and even a lot more difficult in the atmosphere that we're dealing with right now with COVID. So the screening criteria should identify babies at risk. And there are 2 popular guidelines that are frequently used. One is the American Academy of Pediatrics guideline, which is updated in 2013, and also the British 2010 guidelines. And both of these segregate children at risk by body weight and gestational age and other factors. Also, we need to identify who and when to screen. And it is generally accepted that screening should be done at around 30 to 31 weeks post-menstrual age or 4 weeks chronological age, whatever is later. And that this, with a 99% confidence, should pick up pre-threshold ROP. But we also need to see the fine print on the box that says this is a tentative rather than an evidence-based guideline. So there are variations of screening around the world. So this is just a small table that highlights the variations. Canada, UK, Australia, New Zealand start their screening at a gestational age of less than 30 weeks with a body weight of approximately 1.2 kilograms. But however, in China, they encounter babies with severe ROP at a heavier weight, and their birth weight screening criteria goes all the way up to 2 kilograms. Not only is there variation in screening, there's variations in ROP development. So this is another table that has been extracted from a study by a Chinese cohort. Obviously, ROP stage 3 is something that we want to monitor because when it progresses to stage 4, visual consequences are dire. Usually stage 3 ROP occurs in extreme low birth weight infants or infants that are very premature. But however, according to their data, we see children over 1.5 kilograms that are developing stage 3 ROP. ROP screening in itself is quite traumatic. The babies are weak, they have many problems. We put in a speculum, we indent them, we put in dilating eye drops that might have systemic effects. So how can we minimize visits without missing cases at risk? So what do we know currently? So what has been developed recently are a lot of screening algorithms all across the world. And this is credit to a lot of hard work from people around the world. So this is a small table that highlights what are the scores and what are the algorithms. All of them boast a very good sensitivity with varying specificities. And then obviously these algorithms could be quite demanding in what you enter into their system. The old WinROP required weekly serum assays of insulin growth factor. The ROP score needed continuous body weight and gestational age inputs. The pint and chop ROP needed a weekly calculation of net weight gain. The GROP may only be applicable to North American NICUs. The STEP ROP also needed information about the respiratory state, the race of the mother, multiple gestations. All this information may not be readily available. Of course, we have to credit a lot of case reports that have been written and published by ICUs all across the world about how the algorithms performed in their centers. And this is an example of one that was published in Italy, in which they were evaluating the WinROP, the ROP score, the CHOP ROP, and they boasted 100% sensitivity, and it was quite applicable to their NICUs. But however, what is good for you may not be good for me. So this is a study that was published in Canada, the province of Manitoba, and they were evaluating WinROP, and they actually concluded that this was not clinically sensitive enough in their NICU. There was also another study that was recently published as an Indian cohort in 2021, in which they evaluated WinROP, CHOP ROP, and ROP score in their NICU center, and they also concluded that none of these were able to be sensitive enough to replace the traditional screening. So therefore, there are limitations to algorithms. They are all web-based. You cannot export their data. There's limited transparency. Obviously, since we only start screening these children at 31 weeks, all the information gathered beforehand may not be at our fingertips. So we need to rely on the neonatal staff to fill in the data prior to screening. And it may not be easy to get all this information because the baby could have been transferred in from somewhere else. Serum sampling could be quite expensive, and not all NICUs can have finances for that. And like I mentioned before, there are global variations to all algorithms. So this comes to our question: can we develop a score to predict ROP among premature infants in Hong Kong by using very simple parameters? And we actually had our idea from a previous study that was published by Eckert and his group in 2012. So since we were doing annual audits about ROP screening and compliance in our center, this information was readily available for us. So we actually conducted a retrospective study, and we actually looked at data from infants born from 2012 to 2017. And we used this data, gestational and body weight, to develop a multivariate logistic regression analysis using these two predictor variables. And after that, we used the data to come up with a receiving operating characteristic curve analysis to predict the sensitivity and the specificity of our score. And we used the statistical software R, which could be found online. So we enrolled a total of 505 infants. The mean gestational age at birth was 29 weeks. The mean body weight at birth was 1.2 kilograms. And we found that in our cohort, 77% did not develop ROP, and only a 20-odd% developed ROP, and only 3% needed treatment. So we used body weight and gestational age, and then we inputted it into a linear regression model. The coefficient B that you see here was calculated for gestational age and body weight as the constants. And then we used this predictor variable to apply to an ROC curve. And what that is in particular is a graph that identifies the cutoff points for the best performance. And it predicts the positive and negative values, and it balances a trade-off between the sensitivity and the specificity of a test. So this is the ROC curve that we came up with. The green one is the ROC curve when we just looked at body weight as a predictor variable. The blue one is for gestational age, and when we put it in the linear coefficient model, we come up with a red curve, which we named the Hong Kong ROP score. And because we had this curve, then we had to identify the one point on the axis that gave us the best sensitivity and the best specificity. And so that happened to be about 85.1% on this curve on the sensitivity scale, and 84.4 on the specificity scale, which give us the golden number of -102. So this was the formula that we came up with. Babies with a value greater than -102 were more at risk for developing ROP. So this was all in good. We have this formula that was come up from our retrospective audits. Then how does it perform? So what we had to do is to retest this and use it as a prospective validation of our formulas. So we actually applied this formula to babies screened during 2019 and 2020. So the examiner does not know the magic number. They screen as usual, and then we put in the data into an Excel spreadsheet after everything was done. So this is the example of the Excel spreadsheet we have. So we had gestational age in days, body weight in grams. We screened whether the baby developed ROP or not, what was the staging, what we did. And then after that, we just input it into the Express spreadsheet in which they had the formula. And then we'll see whether the formula predicted what actually happened. So these were our results. So test positive here means that the equation would predict ROP and the baby actually had ROP. Test negative ROP means that the equation predicted that the baby would not have ROP and the baby did not have ROP. And it was actually quite high at 98%. So overall, the table that came out from our 2-year study was that the sensitivity was about 96.2%, the specificity was about 82%, the positive predictive value was 61%, and the negative predictive value was 98.6%. So the sensitivity being high and specificity being slightly low is good. And over 80%, I think, was already quite good. Of course, our cohort was actually a very small number, but it actually reflects that the NICU care was quite consistent. So after we were very, very energized with how our formula actually behaved, then we actually proposed to another ROP center, screening center in Hong Kong, to try it out. And so they sourced their medical records, and they actually used our cohort of babies as an external validator group for their formula. And their formula for the logistic regression was a little bit more complicated. They added other factors such as NEC, IVH, PDA, RDS. But after evaluation, they actually concluded that gestational age and body weight were the best predictors. So they actually had their own AOC curve, and their predictor variables for sensitivity was 87.4% and 79.3%. And their magical number was actually 0. So they came up with a PW-ROP score formula as above. And actually, you can actually tell that this formula was quite similar to the one that we came up with, except that the threshold values were a little bit different. And the article that we wrote together is currently in press, and you hopefully will see it in a couple of months. So in conclusion, this is a very simple predictive tool. You only need body weight and gestational age. Each center can actually have their own formula. It will adjust for variations of care between NICUs and the oxygen protocols that are used. It allows for geographic variations regarding ROP development, and it can be used for earlier counseling and to anticipate changes in ROP development. But of course, we need more work on this formula because one formula still cannot replace traditional screening. And we always need to verify our logistic regression formulas by verification of gold standards, repeat analyses, and actually using centers from other places for external validation. But it's good to see that we have quite similar formulas, and so that may reflect similar NICU practice standards across the territory. So future thoughts. We know that ROP is going to be an increased global disease burden. How can we combine this with other modalities to further better our care? Can we combine this with telemedicine or AI? And knowing that there are many places that will have limited access for ROP screening, this is something that we need to ponder. So thank you very much for your attention.